Hi, it's Dr. Centeno, and still trying to get it right at this new location, experimenting with different places to hold Facebook Lives. This one may have too much echo, but I'm going to figure it out. So today we're going to talk about an interesting topic, intracranial hypertension, and whether or not you can look at someone's MRI and determine if they're likely to have symptomatic intracranial hypertension. And, that's one I think is critical because we have a lot of patients who come to us with the concept or idea that they have intracranial hypertension and that's causing their headaches and other symptoms. And so the question then becomes, who's got this? Is it important to know about it? And can you look at existing research to try to determine if you've got this, or can you look on the MRI to try to determine if you've got this, et cetera, et cetera. In addition to that, we have certain clinics that are offering a battery of tests, none of which are a brain MRI, to determine if people have intracranial hypertension. So let's dive into this. Are there findings on your MRI? And many of you who are trying to see if you have craniocervical instability have had a brain MRI. If you have a headache these days, eventually you'll end up getting a brain MRI. So are there findings on that brain MRI that can be pointed to determine if you have intracranial hypertension? So let me go ahead and pull that up here and we'll get started on that. There we go. Good. And as usual, I will answer questions about this topic or pretty much anything. So let me share my screen and we will go from there. Okay, so the title today is, are there unread findings on your brain MRI that could indicate intracranial hypertension? So we're going to talk a little about what is intracranial hypertension. Is it important for CCI patients to know about? Do you need these expensive battery of tests being offered by certain clinics to try to see if you've got this? Or can you just look at a brain MRI that you already have to see if you have this problem? So what is intracranial hypertension? The concept is there's increased pressure in the cerebrospinal fluid around the brain. There's also the concept of idiopathic intracranial hypertension. And that basically means that we don't know what's causing it. And the symptoms in general can include headaches, tinnitus, which is ringing in the ears, up to temporary blindness, double vision, blind spots, neck and shoulder pain, and vision loss. Now, some of these things are also symptoms of craniocervical instability. So there's a big overlap here. So it's very important to understand, in addition to craniocervical instability, that dozens of other medical problems can cause these same symptoms. So can we look at a brain MRI and figure this out? Well, let's see. So the first concept is, can intracranial hypertension be related to the neck? And as many of you know, I've given lectures on intracranial hypertension before. And so we have C1, C2 here. And we certainly know, or we think we know, certainly we can see on imaging studies that when there's excessive rotation at C1, C2, or C1 in particular just tends to move forward too much, you can get some compression on the internal jugular vein because you've got the internal jugular vein running right in front of those structures. Not doing a good job there. Sorry, I've drawn a line. And if we look at this from a cross-sectional standpoint, you can see that the internal jugular vein lives right in front of that transverse process there. And so if the entire C1 vertebrae comes forward, then you can get pressure on that internal jugular vein. If there's excessive rotation, you can get pressure on that internal jugular vein on one side. And in addition to that, the position of that styloid may be important there. So we see this a lot in craniocervical instability or CCI patients. Now, routine brain MRIs, as you know, are often done in CCI patients because symptoms like head pressure or tinnitus are pretty common. So if you report to the average family doctor that you've got unexplained headaches or head pressure, or that you've got tinnitus, eventually you're going to end up getting a brain MRI if you have that report long enough. Then the question becomes, is it possible to have findings on that brain MRI that go unread, that could indicate that you have intracranial hypertension? So before we get into what might be lurking on your brain MRI images, it's important to note that if CCI is causing intracranial hypertension, then the treatment is still to reduce the instability. Same stuff. Hence, in that case, knowing that there's intracranial hypertension is really purely academic, meaning that the treatment doesn't change. The treatment is still to try to get rid of the instability. So today, I'll focus on MRI findings that are rare in normal control patients. And what does that mean? Well, one of the things that I always try to educate patients about, especially CCI patients, is this concept of a doctor looking at an image and saying, aha, that doesn't look right to me. That must be causing your symptoms. And in fact, we need full-on medical research studies to see if a doctor can do that with any one finding. And for example, many of the MRI findings that neurosurgeons will point to, prominent neurosurgeons, and say, yes, that's causing your symptoms, that indicates CCI, we don't have good research on, meaning that all MRI findings are found in normal, healthy controls that don't have the problem, or almost all. So that means that if I take 100 people off the street right now without any problems, what percentage of those people are going to have that MRI finding that I think is causing, or I think indicates that they have some disease like craniocervical instability or intracranial hypertension? And so I only use studies here that found that around 5% of normal controls had the finding. So a low number, 1 in 20 normal people had the finding. So if I see that finding on someone's MRI, I'm fairly comfortable that there's a 95% chance that I'm going to be right in saying that that finding is causing their symptoms. So be very, very careful with this concept. I see this all the time. Patients get focused in on what's on their MRI, and someone tells them that for sure is causing their symptoms, and yet we have no research on whether or not what the doctor is pointing to is just a normal finding found in people walking around with no problems. So that's why I put this floor or threshold in here. So this analysis is based on this very nice review paper that these researchers put together. And they tend to quote this one guy who seems to have done a lot of studies on imaging findings for intracranial hypertension. The first one we'll talk about is an empty cella. So we see some radiologists out there that point to this a lot, an empty cella syndrome. So what is this, the cella that they're talking about? So this is a little spot in the brain where the pituitary gland lives. It's kind of like a little cave, if you will, of bone. And when the cella is empty, it means that there's been some atrophy of the pituitary gland. And so in this one study found that about 27% of people with IIH had an empty cella, and only 5.4% of controls, about 5% of controls. If they had a partial empty cella, meaning that there was just some atrophy of the pituitary gland, but it wasn't complete, this little cave wasn't completely a void of a pituitary gland, then that was even more likely to be intracranial hypertension or idiopathic intracranial hypertension. Now, I realize that only 27% of people with intracranial hypertension had this, But if we see it, we can be fairly comfortable that there's a 95% chance that this is going to be an abnormality, because only 5% of normal healthy people have this. And this is just more information on what we're talking about here. You can see the sella turcica there, and you can see sort of a representation of it here. I'm not quite sure why my cursor's making crazy lines here. But it's also important to realize that this can be present in other problems like systemic arterial hypertension, obesity, and other issues. It can be also associated with pregnancy, lactating, menopause, etc. So we have to be careful. The thought here of why this happens is that as this cerebrospinal fluid increases, the pressure increases, a part of the pituitary will die off from that increased pressure around the pituitary against this little bony cave where the pituitary lives. Another one is optic nerve protrusion. So the concept here is that the optic nerve that jacks into the back of the eye produces what's called papilledema, or the increased pressure around that optic nerve, which jacks into the cerebrospinal fluid there that has increased pressure, gets bigger. And you can see that on an MRI. You can also see that on a physical exam if you look for it. But again, the good news is it's really not present in normal healthy controls, so that's good. But only 3% of patients with intracranial hypertension have this finding. So if we see it, we might be thinking about intracranial hypertension. But again, lots of different causes for this, only one of which has to be idiopathic intracranial hypertension. Also here, we have posterior globe flattening. So the concept here is the balance between the pressure inside the globe of the eye and the cerebrospinal fluid behind it gets off. And we tend to see the nice round globe of the eye on an axial MRI flatten. So it gets flatter at the back. The good news is here, this is found in a much higher percentage of patients with intracranial hypertension, and no control subjects had it. So that's actually now a better thing to look at on an MRI, because it's found in a large chunk of people with intracranial hypertension. And then finally, these small slit-like ventricles. So the ventricles are the areas in the brain, as you can see in A there, where the arrows are pointing, that circulate the cerebrospinal fluid through the interior of the brain. So rather than these getting bigger, they tend to get smaller in intracranial hypertension. And again, problem here is this is of people with intracranial hypertension, but the good news is none of the control subjects had it. So again, remember, just because there are MRI findings that are consistent with intracranial hypertension, if you have CCI, this really doesn't change the treatment plan, but it might be good to know. And it's one of the reasons why I'm a little critical of clinics that are doing a battery of tests here that we don't have this kind of research on, when we can just look at someone's MRI and look at these findings that are well vetted to see if they have intracranial hypertension, or if it might suggest that they do. It's not going to really change the treatment plan. The treatment's really just the same, which is to treat the instability. So I wouldn't waste your money on a bunch of tests when we can just look at your MRI and see what's on there. So let me go to questions here now, and we will go stop share. Okay, let's see if there's some questions I can answer that have come up here. Some advance by Charles Brownstein. Is there a specific type of MRI to rule this out? Is intracranial hypertension treatable non-surgically? So again, important to realize that we're just looking at standard brain MRI. Usually these brain MRIs have hyperintense T2 signals like flare, like most brain MRIs do. As far as non-surgically, if it's being caused by craniocervical instability, that would be the PICL or other procedures to stabilize the upper cervical spine, or surgery to stabilize the upper cervical spine. Doctor, does poor posture and loss of cervical curve cause dizziness and ear and head pressure and difficulty swallowing? Poor posture usually doesn't cause dizziness and ear and head pressure and difficulty swallowing. So the kind of things that we would think about there might be whether or not there's injury to the upper neck or an irritated nerve in the upper neck or craniocervical instability. Those are the things we would think about with those symptoms. Difficulty swallowing can be due either to pressure on the glossopharyngeal nerve, due to things like craniocervical instability, or you can also see big bone spurs put direct pressure from the front onto the back of the swallowing mechanism. John, can you correct IGV compression with a chiropractor as well as PRP? Well, certainly your first starting place would be seeing a upper cervical chiropractor, AO or NUCA, to see if they can help, right? Because if there's something out of position up there that they can reposition and let it heal in that good position, that's the least invasive way to treat this. PRP, I think, gets into the concept that there's craniocervical instability. Just realize of the 8 different types of CCI, only 1 or 2 could be treated with very precise injections of posterior PRP. The rest would have to be treated anterior with bone marrow concentrate using a PICL type procedure. It's been advanced by Harry Winston. This was my diagnosis before my CCI diagnosis. Is there one or the other? Can someone have both? No, Harry, very good question and issue to bring up. Both are really common, meaning that many of our craniocervical instability patients have intracranial hypertension, and it doesn't really change the treatment plan. We're still going to do the same thing. We're still going to stabilize the upper cervical spine to try to get rid of the intracranial hypertension. Regenics, mid-advanced by DB, what are the differences in the symptoms between this and the symptoms of CCI? Not much. That's one of the problems, is there's major overlap. If we had to look at one thing that's common to internal jugular vein compression, intracranial hypertension, is tinnitus. That's a common one. And so in our patients with CCI with tinnitus, there's probably some element of internal jugular vein compression in that group. But again, it doesn't change the treatment plan. We're still going to try to get rid of the CCI to treat the internal jugular vein compression. John, I went to Regenix, got PRP injected into lower cervical, maybe facets, not sure. It got me 75% better. Safe to assume I go for another injection, I'll be 100%. My neck still get tender when I work out or lightly jog. You know, John, I would need to know a lot more about what's going on in your neck, with your neck, to answer that issue. Realize there's dozens of different medical conditions that impact the neck, and each one of those has a different treatment. John, last question. Regenerative stem cell formula that would help at all with a disc bulge? Not really going to help with a disc bulge. The goal there is to reduce systemic inflammation and to provide supplement components that will help stem cells based on our in vitro research, but not going to treat a disc bulge. Lissy, is ICH life-threatening? Not the kind of ICH we're talking about. Now, there are forms of ICH that can be. I mean, one of the causes of ICH that you would need to understand is, for example, a tumor. That could be life-threatening. So we need to understand that all of the big stuff needs to be ruled out in all of these patients. So we're talking here about intracranial hypertension that might be due to craniocervical instability. But obviously we have to make sure that we've ruled out a tumor in all of those people, so that they've had a brain MRI and made sure that there wasn't some sort of active tumor. So it's one of the reasons why we always at least request a cervical MRI in all of our neck patients, because we want to rule out those sorts of things. And regrettably, we've seen clinics that are treating patients in this area. They never got a cervical MRI. There was never one done because they didn't seem to need it, but it is needed to rule out the really bad stuff that no one wants to miss, right? You don't want to miss a tumor in a patient, because you could push that patient into not being treatable just by having missed the fact that there was a tumor there. Imani, please, how can I know if I have CCI knowing I'm from Morocco and don't have upright MRI here nor DMX? Well, I think the first thing would be a telemedicine evaluation. That would include looking at your existing cervical MRI. And then we have some written instructions for doing an open mouth lateral bending using x-rays to try to get a little bit more information. We use that with a lot of patients in Europe. So there are other ways to get there, or at least get closer to that diagnosis, so that we have some sense that that person is highly likely to have that issue or not. Edward, if posterior prolotherapy CCI is going to work, how long do you think it would take for a young patient to begin to see improvement? Not long. In general, posterior prolotherapy in appropriate patients, you normally see responses in 4 to 6 weeks, or maximum 1 to 2 treatments. What I don't really agree with is we have clinics out there that will do 4, 5, 6, 7, 8 treatments in patients that are minimally responding in rapid succession. I don't see we have much rationale for doing things like that. If you're not really seeing a result after 4 to 6 weeks, or maximum 2, maybe 3 treatments, it's time to move on. Edward, where's the optimal time interval for posterior prolotherapy? I think I got that one already. How much anterior translation of the upper neck do you think can be reduced with posterior injections? It depends on where we're talking about. Again, realize if it's the high upper cervical spine, we're not going to see much change. If we're talking about lower cervical spine, C2-3, 3-4, 4-5, we did that research, published it back in 2005, and we were able to get rid of translations of 3 to 4 millimeters in that range. But that's at the lower cervical levels, including C2-3. So T2-3, 3-4, 4-5, 5-6, 6-7, not the upper cervical spine at 0-1 or 1-2. Regenix, been advanced by Sherry Scott. What type of doctor would we go to for a diagnosis? I'm outside the U.S. If you're talking about a diagnosis of intracranial hypertension, this is an extremely specialized area. So the average neurologist probably not going to have a good sense of this. You may want to look up at a local university whether or not there are any experts in intracranial hypertension. Many times universities will advertise this stuff on their websites, or the people on their websites in the university will talk about their research interests. So you can usually pick that up on a Google search. Levon, how Dr. Centeno can partially empty cell and mean compressed pituitary gland as opposed to atrophy? It can. So that's that whole slide I showed where you have the red cerebrospinal fluid sort of putting pressure on the pituitary gland. Just realize that anything that gets a lot of pressure over time in the body that's a neural structure like that is probably going to atrophy because parts of it die off. But it is possible early on to just see less volume because there's just compression. Dr. Centeno, why do you think there are so few regenerative medicine clinics in Europe, and are you evaluating any of them during the Regenix network? Well, yeah, we have several in Europe that we've been evaluating. I think the biggest problem in Europe, though, is that this stuff is not yet covered by national socialized healthcare systems. So, for example, While in the States here, we've been able to get more than 1,000 US employers to pay for interventional orthobiologics or that type of regenerative medicine. In Europe, most of the care goes to the nationalized healthcare system, and those healthcare systems aren't yet going to cover this. I think also in Europe, because that care is available, it's a lot harder to ask patients to pay for procedures like this that they can't get through their traditional medical care system. Here in the United States, patients are paying for their healthcare one way or the other. Even if they've got insurance, they're paying co-pays, deductibles, co-insurances, you name it. Regardless of how good their insurance is these days, they're coming out of pocket if they go see the doctor one way or the other. So it's a little bit easier for them to consider, well, my doctors aren't getting this done. They don't seem to know which end is up. I'm going to have to pay for a super specialist out of pocket to help this. In Europe, that's a lot less tenable, I think, to the average person who considers medical care almost like a utility, like electricity or internet. They're just not used to that concept. So I think that's the struggle with getting a lot of good interventional orthobiologics clinics set up in Europe. Christine, can CCI cause pain in the front of the neck through the jaw and ear? Sure, that's one of the things, or that could be one symptom complex of CCI. That could also obviously be TMJ issues as well. That can cause pain in the front of the neck as the strap muscles try to overcompensate, pain in the jaw, and then irritation of the temporoauricular nerve up into the ear area. So it could be CCI, could be just sort of garden variety TMJ with chronic neck issues. Stacy, can CCI cause atrophy of the cerebellum and that in turn cause feeling of pressure at the center of the base of the skull? Well, atrophy of the cerebellum shouldn't cause pressure pain. Atrophy of the cerebellum would cause discoordination, ataxia. For instance, if someone with cerebellar atrophy tried to put their hand on their nose, they might do that kind of thing. So really not pressure at the center of the base of the skull. That would be other things. Levon, also can temporal fossa arachnoid cyst also hint to increased intracranial hypertension? Not seen that one published. Again, possible, but I think today we're trying to focus on things that are not common in the normal population just walking around. John, any reason why my scaling muscles are so tight? Could it be from forward head posture or the bulge disc or something else? Yeah, John, that tends to happen when the specific levels of stabilizing muscles go offline due to irritated nerves. So then the big muscles have to get involved to stabilize the neck because the small muscles aren't doing the job. And one of those big muscles that commonly gets involved is the scalene. We also see upper traps can do the same thing. Levator scapula muscles can do the same thing as well. Imani, Dr. Centeno, is there any way I can show you the cervical and brain MRI and get at least an idea if potentially have cervical instability or CCI or IIH? Yeah, that would be through a telemedicine visit. So you would want to reach out to Carla at my office and she get a telemedicine visit scheduled. Edwards, posterior injections can reduce lower cervical instability by 3 to 4 millimeters. In theory, could you reduce upper cervical instability by a small amount, like a millimeter or 2? Not really, because we have to look at what the primary ligament stabilizers are in each case. So for in the cervical spine, and make sure that we know that we're talking about translation and flexion. So if we've got translation and flexion, let's say it's C3-4, there are a number of different things that would stabilize that. The disc itself and the anterior and posterior longitudinal ligament. So if the disc was degenerated, that can happen. But if the disc isn't degenerated, then the next biggest stabilizer is going to be the supraspinous interspinous ligament in the back, which easily is reachable by posterior injections. Now, if we go to the upper cervical spine, we've got a completely different anatomy. Now we've got multiple internal ligaments, the alar ligament, the transverse ligament, the AAOM, the PAOM, the SAAOL, the LAOL, a whole host of internal ligaments that can't be reached from posterior that provide stability. And so that's why it's just barking up the wrong tree. You might get a little bit of extra stability, but you're not going to solve the problem. You're still going to have the problem because you never treated the ligaments that are providing the primary stability, because the upper cervical spine is built very differently than the lower cervical spine. It has internal ligaments that can't be reached posteriorly that provide the majority of the stability, where the lower cervical spine, the majority of the stability comes from those posterior ligaments. In most cases, not every case. Stefan, in Europe, neurosurgeons don't even recognize CCI other than heavy post-traffic accident cases. Since I got CCI symptoms, luckily mild ones, I didn't even get new cervical MRI ordered. Yes, well, listen, as I always tell patients, there's probably 6 or 7 neurosurgeons around the world that see 70 to 80% of these cases. In Barcelona, there's Dr. Gillette. So he is certainly a resource to talk to or go see there in Europe. In the United States here, we have maybe 5 neurosurgeons. But that collection of neurosurgeons is seeing the vast majority of these surgical CCI cases that are not the kind of cases where the head is hanging off and there's a hangman's fracture. So that's the problem that you're seeing, right? It's one of a lack of subject matter expertise, just even in the neurosurgical community. Jason, can swelling of the neck joints cause CCI to temporarily 100% resolve a few hours after tripping and falling? I suppose it's possible. I think you may be talking about almost like a honeymoon effect. So when we inject ligaments, we will see a week, sometimes 2 weeks of marked decreased CCI symptoms because of the initial swelling response within those ligaments providing artificial stability. And then eventually the stability kind of goes back to normal as the swelling goes down. So it's possible there could be a honeymoon-like effect if you hit it just right, I suppose. Stacy, cerebellar atrophy not caused by CCI, not sure what does cause it, and PICL can treat it. Yeah, I think that's a different question, right? So the first question was whether or not cerebellar atrophy led to headache pain, and the answer is probably not. This question is cerebellar atrophy caused by CCI? So that's a different question. I suppose, for instance, if you had a substantial amount of Chiari malformation where the cerebellum is already under pressure because it's sitting in the foramen magnum, that CCI could lead to cerebellar atrophy. That being a different issue from does cerebellar atrophy lead to headache pain? Jingesh, how type 2B CCI affects shoulder and mid-back, having shoulder and mid-back cracking and popping with increased frequency? Yeah, shoulder and mid-back pain are fairly common complaints in patients with CCI. Now, sometimes they're not related to the CCI. Sometimes they're separate lower cervical issues that are causing those. And sometimes, I think as I've lectured on before, we're seeing enough type 2B side-to-side instability where we're getting actually irritation of the fibers that go down to those structures. And then there's other things as well, right? We can just see a lack of general stability, for instance, leading to overload of levator scapula. Levator scapula jumps in to try to help, and then you're getting pulling on levator scapula origin at the scapula, and the scapula isn't moving well because it's got this tightness from levator scapula, which is trying to stabilize the upper cervical spine. Era, for providers of PRP on the C2 to C7 area, what should one look for them? A local provider does it with ultrasound. That's considered relatively safe, right? A lot depends on what it is you're trying to accomplish. So if all we're trying to accomplish is those level 1 type injections, where it's a simple ligament injection into the supraspinous, interspinous ligaments, then that can be done competently under ultrasound guidance. Now, however, for some patients where they've had injuries to the facet joints, you would need to inject the facet joint itself. And to inject the facet joint itself, you're going to need X-ray guidance with contrast confirmation. Now, that's a huge jump in knowledge and ability from the first type of doctor. For instance, I could teach the first type of doctor in a weekend course how to safely inject those ligaments. It takes a fellow in our office an entire year to get good at injecting all of the cervical facet joints from C2 to C7 using X-ray guidance and contrast. So it just depends on what you're trying to get to. Yes, the very simplest stuff that will work for, let's say, a third of the patients can be done with just ultrasound, but the other 2/3 of the patients would also need to have those facet joints injected, and that's not going to work in a doctor of that training level. Lissy, ICH happens when you're upright with instability. Could be upright, could be lying down as well. But yes, the instability would be what puts pressure on that internal jerk. I'm on E. I had a mild fall in 2018. I hit my mid-back and my neck, did a small whiplash. From that time until now, I suffer from neck tight muscles, and now it developed to pressure in the head. Could it be CCI? Possible. It also could be injury to the upper neck joints as well, or injury to the upper neck nerves. Lots of different possibilities there. Lissy, can the shoulder instability cause IJV compression to or mid-back instability? No, not so much. More mid-back instability because the scapula sits on the mid-back and the rib cage there. But IJV compression is something that is not going to happen usually in that situation. Adina, is Botox safe for tight muscles in case of CCI? Well, safe and a good idea are probably two different things here. It's not unsafe, but at the same time, we see this cause a huge flare-up and sometimes permanent, but often, most of the times, temporary in CCI patients. Why does that happen? CCI patients need all the muscle spasm they can get. The doctors that do Botox don't generally understand the concept of subfibular instability, so they don't even have a box to put this in. All they know is that someone's complaining of some tight muscles, so they inject those tight muscles with Botox that loosens the muscles and makes that patient more unstable, which causes usually a temporary flare-up, but we've seen a couple of people that have had a permanent flare-up from getting Botox injected when they have CCI. So I would say that injecting Botox into tight muscles is contraindicated in CCI patients, meaning that we shouldn't do it because it's not a good idea, and it has a small chance of potentially causing permanent harm. But for the most part, it definitely causes a huge multi-month flare-up in the vast majority of the CCI patients we see. Mark, what ligaments are involved in stabilizing the occiput and C0? Lots. So we have the alar ligaments that go from the dens to that occiput area. We have the lateral AO ligaments out here. We have the LAOL ligament up front. And those are directly acting on the occiput. I think a better question would be the C0, C1 facet joint, in which case we could also add in the nuchal ligament, the ventrodural ligament, We could also add in to that the capsular ligaments from the front and the back at the C0, C1 facet joint, etc. Okay, any other questions I can answer? I think we're getting into shorter shows because we're getting into the summertime period. Or maybe it's because you guys are getting all your questions answered and you have fewer questions, which would be really great because that means we're accomplishing what it is we're trying to do with this twice a week show. Other questions I can answer out there. So today we were talking about whether or not there are MRI findings that can show intracranial hypertension, or at least give us good clues to whether someone might have it. And I talked about lots of different MRI findings that are not hard to see, but many times won't get read by the reading radiologist. And you don't need a bunch of crazy tests in someone's office to try to see if you've got intracranial hypertension that are going to cost thousands and thousands of dollars. Usually we can just look at your MRI and make that diagnosis. And if you've got CCI, it doesn't really make a difference anyway, because it's not going to change the treatment plan. The treatment plan will still be to try to get rid of the instability. So that's what we talked about today. I'm going to give a little bit extra time here to see if anyone's got any questions that pop up here at the last minute. Sometimes they come through at the last second here just because all of the systems that feed into StreamYard can be slow. Okay, looks like I think we're done for the day. Thanks so much for watching. I will be here this Friday and doing another interesting topic. And same bat time, same bat channel on Friday. So thanks so much for watching, and have a great week.